This webcast is brought to you by Anthelios and the International Dermascopic Society. I'm Vinnie Seiverling, and I'm a dermatologist at Tufts University in Boston, Massachusetts, in the United States. Today, I'll be talking with you about the dermascopic features of amelanotic melanoma. The term amelanotic refers to tumors that are lacking melanin. They have melanocytes, but they do not have lots of pigment or melanin that we expect to see in traditional pigmented melanomas. The term hypomelanotic is also falling under this category. These tumors have some melanin, but very little, and they come across as faint brown, pink and brown, or having pigment only in one area. Amelanotic melanoma can be of any type: superficial spreading, nodular, desmoplastic, or even acral. Clinically, these tumors tend to be pink and can mimic non-melanocytic growths like pyogenic granulomas, warts, or angiofibromas. They can also mimic benign melanocytic growths like intradermal nevi. Clinically, amelanotic melanoma is more difficult to diagnose because they rarely have the features of a traditional melanoma and cannot as easily be detected using the ABCDEs of melanoma. Dermascopically, amelanotic melanomas also differ in that traditional melanomas usually have signs of a melanocytic process, like a pigment network or pigment globules. And most traditional melanomas are disorganized and have a very chaotic distribution of their shapes and colors, making them relatively easy to detect. In contrast, amelanotic melanoma often is structureless or just homogeneously pink, making it more difficult to categorize this as a worrisome growth. Most amelanotic melanomas, however, with the use of dermoscopy, can be accurately diagnosed by looking for vascular structures or shiny white structures. Some of the earliest publications on this topic looked at amelanotic melanomas that were of the superficial spreading type. And they found that there were some features that were negative predictors, meaning if they were not present, they were very much likely to push us away from melanoma. So if milia-like cysts are present, it is unlikely to be an amelanotic melanoma. Whereas if irregular vessels or pink color are present, that is an important positive feature that this could be an amelanotic tumor. In both of these studies, there was a predominance of dotted vessels or linear irregular vessels in the amelanotic melanomas. Vessels under dermoscopy are a very important clue for amelanotic melanoma. When we use our dermatoscope to look at vessels, we want to make sure that we aren't putting too much pressure or contact on the growth because we can accidentally blanch out this important diagnostic clue. One of the most common vessel patterns in earlier amelanotic melanomas are dotted vessels. Dotted vessels are seen here, where we have lots of little red dots all throughout and more prominent centrally. Diffusely dotted vessels can also be seen in Spitz nevi. In amelanotic melanoma, we more commonly see dotted vessels just in one area or centrally. Here's a case of amelanotic melanoma, a solitary outlier growth on the left low back. When we look closely, this is an organized appearance under dermoscopy, and what we see, however, is a chaotic number of vessels. We see pink color as well as white color and what are called linear irregular vessels, in addition to dotted vessels. When we look more closely, we can see these irregular branched vessels. Some of them are looped at the end. They are quite heterogeneous in the way they look. And then in some areas, we have dotted vessels. In sum, the best descriptor of all of these different vessel patterns is the term polymorphous vessels, which Dr. Menzies published many years ago. Polymorphous vessels allow for us to kind of group all of these different vessels under one term. So what is meant by polymorphous vessels is within this amelanotic, hypomelanotic melanoma, we have a milky pink area, we have dotted vessels, and we have linear irregular vessels. Now, this hypomelanotic melanoma also has a peripheral light brown structureless area, which we will sometimes see in these less pink tumors, in the tumors that are pink and brown. But polymorphous vessels is a very useful term to describe the multiple different vessel patterns we see in amelanotic melanoma. Lastly, sometimes what we see is a milky red color or a milky pink color in these amelanotic melanomas. And at times you will see what look to be even vascular globules. Superficial spreading melanomas tend to have more of the dotted vessels, and when we look at these thicker melanomas like nodular melanomas, they have slightly different vessel patterns, but they also have a different clinical appearance. These are firm tumors that appear quickly, grow quickly, and when touched are raised. Of the nodular melanomas, up to half of them are actually pink in color. In addition to having atypical vessels like we see here, where we have a linear irregular vessel, we have a milky red area, pink, and all of these polymorphous vessels, some nodular amelanotic melanomas will also have ulceration, scar-like depigmentation, and blue-gray color. In addition to irregular vessels, some amelanotic melanomas of the nodular type and superficial type will also have shiny white structures. Because vessels are such a common finding in many skin tumors, it's important to be able to differentiate the polymorphous, more atypical, linear, irregular vessels that we see in nodular melanoma from more common benign things like intradermal nevi. The vessels that we typically see in intradermal nevi are comma vessels. Comma vessels are curved and often distributed all throughout the growth or sometimes just at the periphery. Basal cell carcinomas often have arborizing vessels where we have this tree-like vessel in crisp focus going all the way across the growth. We do not tend to see arborizing vessels or comma vessels in nodular amelanotic melanoma. Another clue to amelanotic melanoma are shiny white structures. Shiny white structures are only seen under polarized light. They represent fibrosis and changes in the collagen. However, they're not specific to melanoma. Shiny white structures can be seen in basal cell carcinoma, squamous cell carcinoma, and melanoma. But if you see a nodular or firm papule with irregular polymorphous vessels and shiny white lines, be very worried about a melanoma. So in summary, nodular amelanotic melanoma will lack the traditional features that we see in basal cell carcinoma or intradermal nevi and typically will not have milia-like cysts. Instead, these tumors might be symmetric, have irregular vessels, and sometimes have shiny white structures. Lastly, acral melanomas can be amelanotic. This is a case of a 58-year-old Black woman who was referred to my clinic immediately from the emergency department, where she presented due to pain with ambulation. As you can see, she has a large, greater than 4 centimeter exophytic tumor on her heel. When we look with our dermatoscope, we see an abundance of pink and red color. We can also see there are many vessels. These are polymorphous vessels, meaning some are linear irregular, some are red and globular, others are microulcerations. In addition, there are signs of shiny white lines and some areas of scar-like depigmentation. In contrast to acral lentiginous melanoma that has a parallel ridge pattern, acral amelanotic melanoma may not have much pigment at all. In fact, here at the edge, we have one little hint of pigment, but the most important features we're seeing are atypical polymorphous vessels and shiny white lines. So acromelanoma can also be amelanotic, and be on alert if you see many vessels, ulceration, and if something is large in size. Any acral growth that's greater than a centimeter and ulcerated should raise a red flag for skin cancer. In summary, amelanotic melanoma is something that is tricky to diagnose, but the clinical clues are there. If you see something pink, stop and think and grab your dermatoscope. And under dermoscopy, if you see dotted vessels or linear irregular vessels, polymorphous vessels, and or shiny white structures, it is probably a good idea to do a biopsy. I want to thank the International Dermoscopy Society and Nan Thelios for the opportunity to present, and a special thanks to my mentor, Dr. Ashmar Goob, for his mentorship and contributing some of the slides to this presentation.